My name is Cristina Gasparetto, and I work at Duke University Medical Center. And today I presented the results of a phase 1b/2 study of the combination of a new drug, Selinexor, in combination with Daratumumab and dexamethasone. Selinexor is very exciting. It's a new drug. Is the oral selective inhibitor of a protein called Exportin 1. This protein is very important. I mean, it's actually causing a lot of trouble because when it's expressed at high levels in the cancer cells and is expressed at high level in myeloma, causes the cells to evade apoptosis, so they don't die, allowing tumor suppressor protein to leave, the nucleus. So what the Selinexor does, inhibits this protein, and so pretty much retain the tumor suppressor protein, oncoprotein in the nucleus of the cells, and therefore the cells, go to apoptosis. So it's a very important mechanism of action. And Selinexor is given orally by mouth, which is another class of the drug and has this different mechanism of action. So the Selinexor Daratumumab combination is one of the arm of a trial. It's called the STOMP trial, where Selinexor was given in combinations with others backbone therapy for myeloma, carfilzomib, Dexa, bortezomib, lenalidomide, pomalidomide. And so in the Selinexor Daratumumab arm, we are enrolling patients who have failed at least 3 prior lines of therapy, exposed to both protesome inhibitors and Imids, or refractory to protesome inhibitor and Imids. And we were very pleasantly surprised by the efficacy, the response rate of this combination. First of all, when the Selinexor is given twice a week by mouth, was too toxic. So we had to de-escalate to the weekly administration, and we noticed giving Selinexor only once a week in combination with dexamethasone also once a week, and the Daratumumab as prescribed, the drug was more tolerable. In terms of side effects, adverse events, we had GI, gastrointestinal, nausea, vomiting, diarrhea, but they were relatively mild. The majority of patients had grade 1 and 2 toxicity, GI toxicity, and they were manageable. So we noticed that if patients were able to tolerate the therapy at the beginning, then we could do some dose adjustment, supportive care, and some patients are able to tolerate the drug for a prolonged period of times. We also have seen a weight loss, some low sodium in the blood, and we don't know, but we think it's because with the nausea, patients are not drinking, but just maybe some water, and we see some dilution, but we don't know exactly the mechanism of action. Then we also saw some hematologic toxicity, meaning, we've seen decreasing of platelets, red blood cells, white cells. I want to say that the platelets reduction, the thrombocytopenia, was probably the most common. But with the dose of once a week, we really didn't have any limiting toxicity, which was very good, and that dose became the dose that we chose for the expansion phase. In terms of response, we had a phenomenal response in these, relatively heavily pretreated patients. We have a response of 79% in patients who were never exposed to Daratumumab. And if we include also the minor response, also the clinical benefits, so the overall response was up to 88%. The median time to respond was fast, about 1 month, and we still don't have, we have a short follow-up. Actually, the progression-free survival has not been reached yet, so these are all preliminary data. And so we were, kind of surprised, pleasantly surprised. We have patients, still half of the patients are on treatment. And I think this is a very good, innovative combinations, potentially, very effective The toxicity, we learn how to use the drug, and I think it's manageable. And so I think, further studies, further investigation is definitely going to be very important. So I was excited to present this data.